Okay. Hi, my name is Dr. Kristen Goodell, and I am the Associate Dean for Admissions at Boston University School of Medicine.
From Case Western Reserve University School of Medicine in beautiful Cleveland, Ohio, this is the All Access Med School Admissions Podcast. Hello again, everybody. I'm your host, Christian Essman, and I'm the Senior Director of Admissions and Financial Aid here at Case. This episode goes out to all those listeners who have been requesting Boston University and patiently waiting. I'm finally able to bring you this conversation, so thanks for hanging in there. And I had a great conversation with Dr. Goodell, so I hope that you find it to be well worth the wait. So, hey, let's get right into it. Located in Massachusetts, the Boston University School of Medicine is one of the graduate schools of Boston University. Founded in 1848, the medical school was the first institution in the world to formally educate female physicians. It was originally known as the New England Female Medical College, but was renamed Boston University School of Medicine in 1873 when the medical school was acquired by the growing university. In 1864, they became the first medical school in the United States to award an MD degree to an African-American woman. Interestingly, their other claim to fame is that they were the first medical school to connect the study of medicine with the care of patients, integrating clinical practice, education, and research. BUSM, as they're called, is located in the heart of Boston, where its primary teaching hospital, Boston Medical Center, takes care of predominantly underserved and extraordinarily diverse population. The hospital's motto is exceptional care without exception. Not only does the Boston Medical Center operate the largest level 1 trauma center in New England, but they have the largest network of regional community health centers in the area. To be sure, BUSM is a social justice medical school. This emphasis on social justice is evident in their curriculum and the extracurricular activities for students, in the faculty's areas of research and expertise, and in the patients they serve. Interestingly, all of this social justice does not make BUSM a community program or a primary care school, but rather is a major research institution with international expertise in emerging infectious diseases, chronic traumatic encephalopathy, substance use disorder treatment, and the impact of social determinants of health. BUSM is a private institution and accepts applications from all U.S. citizens, international applicants, including Canadians, and those with the DACA status, but on a case-by-case basis. For the entering class of 2021, the Boston University School of Medicine received 12,090 applications and interviewed 993 applicants for a class size of 150, which included 6 MD-PhD students. 60% were women and 16% self-identified from groups underrepresented in medicine. You've already heard a little bit about Dr. Goodell, but let me share some additional information about her background with you. In addition to being the Associate Dean for Admissions, she is also an Assistant Professor of Family Medicine at Boston University School of Medicine, and she is an Academy Medical Educator at BUSM, coaching, advising, and teaching clinical skills to all 4 years of medical students. Dr. Goodell received her bachelor's degree from the Colby College and her MD from Columbia University College of Physicians and Surgeons. She completed a residency in family medicine from the Tufts University Family Medicine Residency Program and the Tufts Master Teacher Fellowship from Tufts University School of Medicine. Dr. Goodell is interested in leadership development and in growing a diverse and effective physician workforce, and has served on multiple national leadership positions, including co-chair of the Leadership Development Task Force of the Council on Academic Family Medicine, treasurer of the Society of Teachers of Family Medicine, and chair of the National Council on Graduate Medical Education. She is currently a member of the AAMC's MCAT Validation Committee as well. Okay, there you go. Now let's just jump right into my conversation with Dr. Goodell. Enjoy. Awesome. Well, I've been looking forward to meeting with you, and I know there's a lot of people listening to this that are looking forward to hearing from you, because I've received their emails saying, can you get Boston University to come on? So thank you for joining me and coming on my show today.
I am delighted to be here.
I have so many things I want to ask you. I have a ton of questions on my sheets in front of me, but this is my selfish one. I'm always fascinated as to how did you land in admissions? Like, what drew you to this realm of medical school and this part of the process?
Yeah. So I'm happy that you asked. I think it's actually kind of interesting. So, I started off my career really as a medical educator. And actually, I should go back a little further because this is interesting to some people too. I went to medical school and actually matched into general surgery, and I did 3 years of general surgery residency, and then I switched to family medicine.
Oh my gosh.
So that's a whole other story. But is kind of interesting. And when I did my family medicine residency, one of the things I had the chance to do during residency was to begin teaching. I did this longitudinal teaching elective. I knew that I liked to teach. I had done it in various forms, like even as a high schooler, and then in medical school, I helped run our student coaching program and things like that. And so got involved in teaching medical students. And then really after I finished my family medicine residency, went right into what we called the Master Teacher Fellowship. And so that was like, I was seeing patients part of the time, but I was also teaching medical students and learning about teaching and learning and developing curricula. And then from there, basically ever since I finished that, I've always had a what used to be a 50-50 split between patient care and academic work. The jobs went through a couple of iterations. I had started at Tufts, and then I moved over to Harvard Medical School. And while I was at Harvard, again, my primary focus there was education. I was working at the Center for Primary Care at Harvard Medical School, kind of leading their efforts to focus education a little bit more on primary care. And I happened to participate in the admissions committee because my boss, I guess, suggested that maybe I would like to. And I thought, oh, that sounds fascinating. I would love to do admissions. And so I was on the admissions committee there, and I found out that I just absolutely loved it. And it was the most kind of fun thing that I did, and it didn't feel like work to me. And it of time. So I would have colleagues that would say, Kristen, you should really ditch the admissions committee. It's just taking too much of your time. And I was like, oh, don't make it up. I love it. So yeah, that was great. And then after I was at Harvard for about 5 years, I started to realize that it was time for me to take the next career step. And I thought what I wanted that next step to be was an associate dean role. And so I actually kind of figured that I was probably going to be an associate dean of education somewhere. And I was actually thinking about, all right, I've got to look at all the medical schools across the country. Like there are only 150 of those jobs in the country. So have to look everywhere. And I also thought, well, I would also consider doing student affairs because that gets you working a lot with students, or possibly admissions. And so I was sort of planning to make this big leap and maybe have to relocate. And then a friend who was working at BU said, hey, BU's Dean of Admissions is retiring and they're going to hire somebody. And so I thought, okay, well, sure, I'll throw my hat in the ring. There's no way they would hire me to do admissions at BU. I didn't go to BU and I didn't train there. Yeah. Like, why would they do that? But it worked out. And, one of the really kind of amazing and fortuitous things that happened is it turns out that BU is really a leader in holistic review. My predecessor, Dr. Robert Witzberg, really sort of pioneered that term, published about it in the New England Journal, about this way of looking at applications to medical school that took into effect lots of different things. In other words, not having strict cutoffs or filters. Although I had not read that article and didn't know about Dr. Witzberg's kind of eminence in the field and didn't do any intel beforehand, when I came for my series of interviews, it just so happened that that's the way I already was thinking. And one of the stages of my interview was they actually gave me a test they had me do a task. They gave me a bunch of applications with the information redacted and said, all right, we're putting you in a conference room. You have 30 minutes to review these applications, summarize them briefly, and then decide who you want to accept, who you want to waitlist, and who you want to reject. Ready to go.
Oh my gosh.
Wow. And then they were like, and then you're going to come talk to us about it. So I did that. And, then I walk into this conference room where the interviewers were. And again, it's me and 10, I guess, 8 or 10 people that were all, it was a big group interview, but I was the only candidate. And they had read my responses that I had typed out, or, my summaries. And it was really interesting. It just turned out that the way I was reviewing and summarizing those applications was totally consistent with the way Boston University wanted to do it, which is to say that I was, looking at the whole application and trying to figure out who is this person and what are the special things that they bring to the table, and how is that going to contribute to the particular mission of this school that we have here. So it just worked out really beautifully that was, that I was kind of in line with what they were doing already. And so it made it a very natural fit. And so, I got the job.
I guess the moral of the story is don't count yourself out, because had you not thrown your name out there, gosh, that's amazing.
Yeah.
And you haven't worked a day since. So,
basically, I love the stuff I do.
That's great. That's great. I love that. You have great jobs. Dr. Goodell, what do you do for fun? What's something that people are surprised to know about you that you do for fun?
I gotta tell people everything, so I don't know if there are that many surprises. I think the thing that comes to mind is that I like to cook. I cook dinner for my family basically every night. And I actually realized this past year, 18 months or so, how important that activity is for me in terms of my transition from work to relaxing time. And it's good transition, and what it really is it's just exactly the right amount of relaxing distraction for me. So I have more energy than most grownups, and I don't like unstructured free time. So like going home to make dinner, I don't. So I'd like, if as soon as I have free time, I structure it. I like put a bunch of things. So anyway, but the process of like making a dinner and kind of being creative with cooking is perfect because it's not hard or stressful at all, and it gives my brain like just enough distraction so that I'm not like fretting about work or fretting about my children or something. I'm not fretting at all. I'm just like focusing on like, what else should I put in the sauce?
Oh yeah. Oh, that's great.
Yeah.
And then really everybody benefits around the table.
And win.
Yeah. Oh, that's cool. Yeah. So I thought let's start with the curriculum, the school details, and then we'll transition and talk about the admissions process. And so let's bring people in to start to understand what are some of those important things that you like prospective applicants or current applicants to know about Boston University. And we can go in a lot of different directions, but maybe the highlights of the first 2 years of the curriculum. What does that look like for students when you're talking to people and they say, tell us about the first 2 years of the curriculum? What do you want them to take away from that?
Okay. So I would say is, first of all, the way that you understand Boston University School of Medicine compared to our peer schools is that we are a social justice medical school, right? Now, all medical schools take care of a diverse group of patients. 100% of them are going to say that. And they're all going to tell you that they care about social justice. And I mean, they do all care about social justice. I don't mean to be dismissive of that. But for us, that's like our core mission, right? And I do think, I think a thing for applicants, it's a little bit hard to understand, but I think is important to understand is that like, where the range of colleges, the spectrum of colleges that you could go to is immense, right?
Like 5,000 colleges and universities.
Yeah, exactly. There are some tiny, there are some huge, there are some really structured, there are some very flexible. They're like, like part-time, full-time, like it's just an enormous range of where you can go and get a college degree. The spectrum of medical schools is not like that. There are, 156 of us or something like that. And we have to all teach the same stuff. And we have to partly because that's what you need to know to be a doctor, but also partly because it's required or else we lose our accreditation.
That's right. Yeah.
So it's not a huge spectrum. So when you are looking at schools and you're like, I don't know how to tell the difference between these schools, they basically all sound the same. It's because And I mean this to sort of be reassuring to people, because if you were inclined to stress about which school is going to be the best, I would try to worry about that less if possible, because any of these accredited medical schools is going to get you to your goal, which is be a doctor. And to a pretty significant degree, it really doesn't matter which one you go to. You're going to get to be a doctor, and that is the point. That being said, you do have to choose. Okay, which out of those 150, whatever, you're going to apply to. So, all right. So how we stand out is that we are a social justice medical school. You asked about the curriculum in the first 2 years, and this is one of the ways that where you see this kind of social justice idea come into play. So for starters, we have a standalone course called Patient to Population Health, which is basically epidemiology, biostats, ethics, and essentials of public health. And that is a course that happens in the first year. It is it involves project work and small groups. It's very much team-based learning. There are almost no lectures in that class. And it's very sort of community focused. That when I say project work, we have everybody doing a project with a community organization. And that's really cool. So that's one thing, and that not all medical schools have that. Again, those are topics that have to be that the accrediting body tells us, but some schools do it mixed in with other things. And we here think no, this is really, we have so many people focused on this. We want to highlight it. So we pulled it out. But then in addition to that, when you look at the rest of our curriculum, you also have social determinants of health and race and gender and sexuality, and all of those issues are really woven into the fabric of everything else you're learning. So, there are sort of, besides the patient population health course, there are two other primary courses that happen during the first 2 years, which is actually a little shorter than 2 years. So during the pre-clerkship curriculum, one is a longitudinal basic science class that's divided into organ systems, as is many other medical schools. And then the other, and that one is that's sort of like the hard science class, right? Then the other course is doctoring, and that one is it's not all. It is where you learn interviewing, physical diagnosis, and clinical reasoning. And basically for medical students in the first and second year, you have 2 afternoons a week dedicated to doctoring. Usually one of those afternoons is a small group session, and one of those afternoons is with a patient or with patients. And so just to give you an example of how we kind of, again, weave the social justice aspects in, when we have the case discussions, it's never just a case of a patient with asthma. It'll be, so the topic of the day, and this is taught along when students are learning pulmonary and respiratory medicine, right? So it's taught during that time, and they're also doing the chest dissection.
Okay, anatomy, right. So it all is lined up.
Exactly. It's all lined up. And so you'll have the small group discussion, 8 students, 1 faculty member, and there'll be a case. And so one of the learning objectives will be to sort of get a better understanding of asthma in the context of a patient. Another learning objective will be, how do you do an interview with a child? Because in that case, the patient is child under 5 years old. And so you have to interview the parent. But then, the patient has a whole story. And so the student's objective is to get the whole history, not just to ask about asthma symptoms. And these are the 5 questions you ask to understand how the asthma is going, but also so tell me where your family is living right now. And how does Roberto spend his time during the day? Is he home with you, or does he go to school? Okay. Who else cares for him? What are some of the, just learning, you got to learn all about that stuff.
Get animals in the house and
exactly. And then, another part of the case is management planning. And so the management planning involves stuff like, okay, so the gold standard for asthma care is an asthma action plan. So who needs to have the asthma action plan? Well, certainly the parents, but then also his uncle takes care of him sometimes, and he only speaks Spanish. So we got to make sure we get the Spanish version asthma action plan. And then he's going to go to pre-K. So we got to figure out what the school needs and communicate with them. And then we need to talk about, all right, and so how can we address, so you live in this neighborhood near us called Via Victoria, and we need to figure out with Via Victoria, what can we do to ensure that the home environment is as optimized as it can be with regard to pests, with regard to mold, all these things that people who are renting don't necessarily have control over and often are kind of worried about bringing up. So how can we help with that? So we weave in all these different factors into our case discussions at the same time as we're saying, okay, so you said you did a physical exam and you heard a wheeze. So what is that exactly? Like, what is that sound? Like, what's, okay, yeah, what this is sound, but like, what's making the sound? Oh, okay, so fine. All right, so it's air through a constricted airway. So, all right, but what is making the airway constricted? And how do you get from like pollen in the air to a constricted airway? Like what's happening at the cellular level? Like what is the chain of events at the cellular level that produces that? So we really bring in all these things. You can probably see I'm excited.
Yeah, and I'm excited because I think people listen like, that sounds so cool. It sounds fun and engaging and all those different aspects, kind of weaving it all and pulling it all together.
Yeah, that's actually, by the way, like why being a doctor is fun, because that's actually the job.
Yeah.
Yeah. So, and it's to think about, like, at the same time, to think about the human and also the complicated science. That's like the job of being a doctor. So this is like what we, medical schools in general, but in particular, we are really trying to focus on. So that's another way that we weave kind of the social justice and the social determinants of health into our curriculum. It's really part of everything going along.
Yeah, that's really cool.
One more thing. Can I say one more thing?
Yeah, this is all about you.
Okay. So this is a new innovation. So this course has been hugely revised. It's only we're just starting up the third year for this course. There were things preceding it, but this is a new version. And one of the cool things that we're doing now is that you have your doctoring group of 8 students and 1 faculty member stays together for the whole 4 years.
Oh, wow.
So in the first year, you've got a group of students and a faculty person, and that faculty person is also your advisor. So they teach you in the classroom, leading you through these case discussions.
Okay.
And they're also advisors. So we're the core advisor, making sure that you're like settling in okay. Like I actually just am realizing I meant to bring in treats for my first years because they have their first exam today, and I totally forgot. Oh, well. Sorry, you guys.
Treats were on their way, but just not today.
Failure of follow through. Anyway, so we are advising our students and trying to just make sure they're settling in and that they're doing what things they need to do in medical school. We make sure that they have resources they need for academic support or social support or mental health support or whatever. Then in the second year, the people who teach doctoring begin to assess their students. And so what that means is you can't have your advisor assessing you, because that's right. Students need to have an advisor they can trust, and they don't have to be worried like, oh no, if she thinks that I'm having a bad time, she's going to give me a bad grade or whatever. So what happens in the second year is then I will keep my advisees, but I'll get a different group to teach in the classroom because I also assess them. So now I've got 2 groups of students starting in the second year going forward. And one group I continue to advise, and the other group I continue to coach and teach and assess. So in the second year, it's the same kind of thing in the classroom, leading the case discussion, teaching physical exam. And then in the third year, we're doing these things where we observe all of our observation students. We do 3 observations kind of in vivo while they're on their clerkships. And so we just pop in, we have a time, we go, we meet our students, we watch them do something with a patient, and then we give them feedback about it. And then we do that again in the 4th year. And the idea is that we really want to make sure that students that their clinical skills are not diminishing over time. A thing that people don't like to talk about that has been not great about medical education is we teach this stuff in the first couple of years, and then we send people to 3rd year and we're like, I'm sure they're doing it in the clerkship, but far too often, nobody watches them. I went to medical school a long time ago, but I don't remember anyone in the 3rd year of medical school ever watching me do a physical exam. Like maybe somebody caught me doing part of it, but nobody ever said, hey, you do a blah, 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 and I'm going to watch. And that's really been the case. Like people, maybe they catch a little bit, but maybe not. And so we think that that's not good. And we think that we need to be like careful to make sure that everybody is getting observed and getting feedback. And it should be from a trusted person that's been watching you all along and has a sense of who you are. And I guess we hope that this creates a really supportive and rigorous learning environment. It's so interesting. Like, one other thing about following up with people and watching people through their third and fourth years that I think is so important. I've heard a lot of people who are concerned about grading in the third and fourth years and the subjectivity of it and the possibility of bias. And I think what I hope is that having somebody who's, again, you've got this relationship with and who's known you over a long time will help to offset those concerns and offset problems if they're happening. Even if you look at the good side of medical school, I can promise you that there are students who I've had a really favorable impression of because of their work in the classroom. And then when I see them actually doing something kind of on demand, like, hey, it's Tuesday, here I am, let's go find a patient. And they do it. And I'm kind of like, all right, actually, they missed a bunch of things. We need to go over this. And that's who otherwise I was like, oh,
they're going to be fine.
No
they crushed the first 2 years.
Yeah. Which is, by the way, like, I think that's what happened to me in medical school. I think that I graduated and a whole lot of people thought she's fine. She's going to be fine. She's fine. And I mean, I suppose that's true, but like, wouldn't it be better if somebody had watched and said, like, pretty good, but you could do this better.
Right. It sounds like there's a lot of touch points. There's a lot of hands-on time. Students feel supported. And for you as the preceptor or faculty member, you get to know each student where, like you mentioned the word coaching, like some people, maybe he's a little more reserved. I think sometimes he needs to, come out a little bit more and be, can't be walked on in rounds or something. And somebody else maybe needs to tone it down a little bit. And you kind of figure out where their strengths are and where areas they need to work. I don't want to say weaknesses, because there's areas of improvement. We're all working on something like that. And that's exactly. Really cool that you have that very specific mentorship program going on.
I think it's really, I think it is, I think it's going to work out well. I don't know how. I'm a person who believes in assessment, and I don't know how to really measure the impact of this program. But as far as I know, it's fairly novel in the country. I don't know of other places that have it set up this way, where you follow people all the way through with a specific focus on clinical skills. And now that we're not having this step to clinical skills exam anymore. It's actually exactly this kind of thing that I think is going to be essential. So I feel as though when residency programs look at our students, they're going to read the evaluations that our school produces and be like, oh, this sounds actually pretty legit. Like somebody who was really paying attention, as opposed to they seem to be fine on clerkships.
Yeah, I know. I've read a lot of medical school websites, particularly for this podcast thing, and I've not seen something as unique as that, and as that small group longitudinal kind of mentorship tracking and along the way. I have not seen that anywhere. So right on. That sounds really cool. I got from my research that a lot of the students' clinical work is done there at Boston Medical Center. You work there. Tell people what's Boston Medical Center like? What's the patient population like? What is the vibe in that place?
Yeah, it's really interesting, and it's maybe different than what I would have thought before I came here. So we take care of a predominantly poor and underserved. And by that, I mean 75% of our patients have Medicare or Medicaid or both for their insurance. In Massachusetts, 98% of the population has insurance because we passed a law about that 5 years before the Affordable Care Act. I will just point out, still working. We are not bankrupt yet.
There you go.
Anyway, rest of the country, pay attention.
I'm just saying.
2% of our population in Massachusetts doesn't have insurance at any given time. Sometimes that's because somebody just fell through the cracks, like they lost their job and they didn't get around to signing up for something yet. Sometimes it's people who've said, no way, man, I'm not buying that stuff. And sometimes it's people who are afraid, like they're undocumented, know what they are able to get. They're afraid to call attention to themselves. Anyway, all those people have to get care somewhere, so they get care at our hospital. Okay. There's one other place, and it's out in Springfield, which is a couple hours away. So Right. So poor and underserved. Another way to sort of think about that is that about 25% of our patients are unstably housed. And so sometimes that means homeless in the way that people typically imagine homelessness, which is to say living on the street or in a shelter. But a lot of times it's something that's not quite that, but not quite stable either. So they're, maybe it's a family who has got like, a couple of kids are staying with my sister, and then I'm going to stay with my friend, and my husband's going to stay with his mother for a little while. Just people
tough.
In different places. Yeah. Sometimes it means a family that's kind of giving some money to another family who has an apartment that they're renting, but like can stay as long as it's working out. There are no problems as long as nobody finds out. So 25% of our patients are unstably housed. So when we talk about underserved, that's what we're talking about. And I think I knew that before I came here. That's Boston Medical Center's role in the city. We also have an enormous emergency department that is very well known. It's a level 1, it's the biggest level 1 trauma center in New England. We get 35% of all the ambulance traffic in Eastern Massachusetts. So it's sort of known as this is where you come if you get shot or stabbed or whatever. So I think any of those things. So I was kind of mentally preparing myself for some place that was kind of tough and gritty, and
something you'd see on like a Thursday night, prime time on NBC.
Yeah. Exactly. Yeah, something like that. That's like what I had in mind. And I was ready. I was like, yeah, cool. I've always wanted to help the people that need the most help. Like, awesome, I'm going to do that. And then it turns out actually, the hospital doesn't really feel like that. It is extraordinarily well run. I mean, really well run. It's kind of unusual for me to praise a bunch of administrators, but I think they're doing a phenomenal job. This hospital feels to me like every other academic medical center I've worked in, which is now a bunch of them. It feels like Beth Israel Deaconess. It feels like Columbia Presbyterian. It feels like Tufts. You know what I mean? Like these are the other places I spent time. It doesn't feel chaotic. It doesn't feel tough and gritty. A little example is like how unbelievably smoothly we managed things for COVID. And our hospital was really one of those places that was inundated. We were in what we called surge capacity. We stopped all of our elective procedures. We stopped ambulatory everything except for the emergency room. We changed the pediatric floors into adult COVID wards. That was what we were doing at the beginning. And yet it felt fine, sort of.
Yeah, quote unquote fine, but it just...
Yeah, the organizational part felt okay. There was really good communication from the administration. This is what's happening. This is how many patients we've seen today. This is how many in the ER. This is how many in the ICU. This is how many cases pending. This is how many staff have been infected. The vaccine rollout was so smooth. I got my first vaccine on December 22nd of this year.
Sheesh.
No,
I got my first... 2020 was a blur. So but I know what you mean. And
it was the way they did it was really smooth. They were like, here's an email. They were like, we're saying, they divided up the staff. Everybody was assigned to a day. You got an email. Once you got your email, you could call and make an appointment. No lines, no chaos. All you needed was your ID. You get your shot. It's been handled so smoothly and effectively. And I guess the other little thing I would say about, how nice the hospital is that I switched my primary care doctor to be a doctor here. And I got a primary care doctor for my husband to be a doctor here because, and we've had, diagnostic testing and different things done and it was supposed to do. And it's fine. It's totally pleasant. Yeah. I also just really forgot to get blood drawn this morning.
Rats.
I don't know, I've had a lot of time. So anyway, I really think very, very highly of this place and I'm a fan. The other thing people should know in terms of what it's like to be here is that it's just the diversity of our patient population. And again, this is another thing where every medical school will say, we take care of a very diverse group of patients. Here's what I mean by that. 32% of our patients don't speak English as their primary language. And so lots of times applicants are like, oh, so could I use my medical Spanish? And I'm like, yes, also, if you happen to speak Haitian Creole, Vietnamese, Portuguese, Cape Verdean, like all of those things use every day. So the average number of languages accessed through our interpreter services every day is 72.
Holy
like,
moly.
can you even name 72 languages?
Yeah. Gosh.
So we just have people from everywhere. We have special clinics for refugees. In our doctoring course this coming week, one of the sessions that we're doing for doctoring is a session about trauma-informed physical exam. That's being led by doctors who work in our refugee clinic because they operate under the assumption that all refugees have trauma. And so they talk about, okay, specifically, what are some things to keep in mind? They talk very clearly about like, these are the kinds of words to use and to not use. And these are the things that you should, these are the ways to approach the physical exam that are less likely to be perceived as threatening or whatever.
Yeah. Oh,
it's really, so, I mean, that's what we mean by diverse. And, you were saying, oh, you see patients and probably the story I should have said just succinctly would have captured it was, I can think of, there's a recent morning that I was seeing patients in clinic, and this is so like classic family medicine, right? So I see 12 patients in a morning. So among those 12 patients were the 13-year-old son of one of our staff members who was there with what turned out to basically be growing pains. He's 13 years old. He's like 6 feet tall. I don't even know what to say. I conducted a visit with an interpreter with a man who was 65-ish years old, a Polish interpreter. He was brought in by his daughter who was worried that maybe he was depressed, and he was. So we conducted a visit to address his depression, diagnose and treat his depression with a Polish interpreter. And then there was another patient that I saw that was Cape Verdean and had sort of came in with her family and was being seen in follow-up from COVID recovery. Another person who had spoke Spanish and had a paronychia, which is an infection of the fingernail bed. Just all these. That's the kind of.
It sounds like
day.
You will see, as a student, you will see a little bit of everything under one big roof at Boston Medical Center. That's exciting.
Yeah. And our patients are pretty complicated, this is different from my previous practice. Which before I came here, my practice was in the suburbs. I was still a family doctor, so still lots of variety. My practice is in the suburbs. And the patients here are much more complicated than in a typical kind of outpatient suburban primary care. And a lot of it is because people come from other places. A lot of times they've had kind of spotty medical care. So people are sicker. They have more problems. They have more unusual problems.
So you can do your clinical rotations at Boston Medical Center. But another unique thing I found is that maybe you could go do 6 or 12 months at Boston University Kaiser Medical in California. So how does a student go coast to coast and maybe serendipitously schedule their third year clinical rotation during January, February, March, April in California, San Jose or Santa Clara?
Yeah. So, the Kaiser, so we basically have it's not a track. It's really just sort of like a branch campus out there. And it's only for the third year. Mm-hmm. And we have an affiliation with 2 of Kaiser's campuses, and our students can choose to go out there. They can choose to either go for all or half of their third year. There's a limited number of spots, so there's a lottery for it. But if you're interested, you say, okay, I want to go. And then you go and you do. The way it works is that you pick your rotation, your preferred rotation order, and then your sites. But if you're wanting to go to Kaiser, the first thing is I want to go to Kaiser, and then you pick your order. And they try and set it up for you. It's really cool. We like most private medical schools, have a lot of students from California. I was just going to say, it's nice for them. Yeah, you guys do too. California turns out a lot of free meds. So a lot of the students that go there are students that live there or that are from California. Decide, I might want to go back there for residency, or I think it'd be nice to be close to home. One of my advisees is going, and she is in fact managed to schedule the winter part of her third year, so that she's going to be in San Jose, which is awesome.
Convenient. So that's great. Very cool. Very cool. This is very exciting stuff.
And I should say too about third year. So the pre-third year clinical work is basically entirely done either at Boston Medical Center or one of our community health centers. So we also are affiliated with the largest network of community health centers, in Boston. And so some students rotate there, like to do their doctoring work. But once you get to third year in it, you can choose rotations at BMC, but you also will likely have some rotations elsewhere. Like, for example, like at the VA, we have several different VA sites. We have a couple of, there's Roger Williams Hospital in Providence, with a couple things just in and around Boston and community hospitals. And I actually think that's a really good idea. It is a good idea to be in different hospitals and realize that the way my school does it is not the be all and end all. In fact, there are different ways of approaching the same problem, and they're all fine.
One more thing I wanted to ask you before we switch gears and talk about the admissions piece is that you'd mentioned social justice is a big piece, and I get the feeling your students are very social justice minded, yet you don't have a community service requirement, which I think is kind of cool. Like you are looking to attract students who want to be involved in the community somehow. And you just know, I have to believe you just know, like when they get here, they're going to bring that track record with them. We're not going to make you do it. We bet you're probably going to do it anyway.
Yeah. Right. That's exactly right. We have the most popular thing for our students to do besides going to class and studying is that they participate in some sort of a service organization. And right now, I think 17 of them, and they're all student led. So they change a little bit over time based on student interest and need. Kind of everybody does that. And it's exactly right. I would say in general, we're not that big on requirements. We also don't have a research requirement, but 85% of our students do research while they're in medical school. More than 50% graduate with their names on a paper. So that's really good. And again, there's no requirement for it. It's just, we just make it really easy for people to do. And we collect a bunch of people who are jazzed about it. And so they come in and they like, oh, wow, you're doing that. That's cool. I wonder if I can do that or something like that. Maybe just twist on it. And so, that's who we get. And that's the way you sort of see that play out here.
Is there, before we talk about admissions, is there anything that you wanted to highlight that I didn't ask about?
I guess the only other thing that I would mention is the fact that we do a lot of research. So I think sometimes when people hear social justice, they tend to think about like, oh, is it like a community medical school or a primary care school? And that's actually not the case. The interesting thing about the way we do social justice is actually that like we're a giant research university, you know what I mean? And so 85% of our students do research. And it's what you often see is that those things come together really effectively. So for example, one of our biggest research projects right now is that we are the lead site for a major national multi-center trial that is validating a specific tool to ask all patients about their social determinants of health. It's called the Thrive screening. And it's in our EHR, it's done with every single patient. This is like, the idea is to see like, okay, if we ask people about these social determinants of health and then address them, because that's, like ethically speaking, you don't ask things if you're not going to do anything about it. So, so if we can ask and then address these issues, is it going to improve people's health? Which sounds like a very foundational question and the kind of thing that people might be like, thanks for spending my tax dollars on that. But we don't actually know though, right? Like we don't know if the medical system can effectively intervene in improving people's health by way of social determinants of health. But it seems awfully important to figure that out. So like that's a huge NIH funded trial. So it's an example of how kind of research and social determinants of health come together. Another example is, we have got an enormous grant to basically address addiction in the state of Massachusetts. And we're specifically working with certain communities. We have a ton of expertise in that area. Again, lots of students involved. That's a sort of that's got its tendrils in a whole bunch of different places in and around the hospital. but then again, we do stuff that doesn't have anything. I mean, it all has some social determinants of health, but that's not as directly related. Like we've got this big Center for Chronic Traumatic Encephalopathy. We've got the NEDL, the National Emerging Infectious Diseases Laboratory. That one got really famous over the last.
I would think so. Yeah.
So I think it's just good for people to be aware that that's the context. This isn't like a sort of scrappy little situation where we're out there like just working to try and chip away and make things better. It's not a startup, I guess is what I would say.
Very well established. And it goes back to your point that that's one of the core of the mission statement or the mission of your school. Great stuff. All right. So now I think people are fired up, and I would think I'm kind of fired up. So one question I usually transition to is, all right, so what are you looking for in people? But you've already answered it because I looked on your website. You have a great website, by the way. And so people listening, go to the website because they have these videos and you're going to see Dr. Goodell. So you're hearing her now, but now you can see what she looks. And she answers the question, like, here's what we're looking for in people. So I guess, it's a big question, and it's probably the most difficult one to answer because we get it all the time. Like, what are you looking for so like last year, I think you guys got like just shy of like 10,000 applications or something.
Last year we had 12,090. Yeah.
The year before it was just shy of 10. So yeah, 12,000 last year. I guess a question that pre-meds want to know is what gets me to from 12,000 into your interview cohort? How do I, what stands out? How do I get to that point? And how do you answer that? Because it's a tough one.
It is a tough one. And, I guess I think that there is no formula because we don't use a formula. So what I hope that applicants can see is the pluses and minuses of this approach. So I know that people would like it if we were, or many people would feel sort of more comforted if we were able to say like, okay, you need this GPA and this MCAT score and this many hours of this activity and this many whatever. The problem is that none of us really think we think that that's going to leave people out.
Sure.
If we do that, there are lots of people that, would be terrific doctors who had some different thing that didn't have them, didn't give them the chance to do whatever those things are. And it doesn't seem right to just, we could, we have a lot of applicants, so we could just be like, we'll just make the rule.
Put some AI into or some triggers in, and it'll just push out these, students that met that criteria.
Yeah. But I guess so far people are too complicated and too interesting. And the thing is like, we like complicated and interesting people. So we don't want to kind of set those things. So in other words, the bad news is it makes it kind of stressful because there is no way that I can say look, if you just do these XY things, you're definitely going to get an interview. I can't. On the other hand, the good news is that it creates opportunities for people to demonstrate their excellence in many different ways. Okay. So that being said, in terms of what we're looking for, I think that, the first thing that you have to be able to do is that you have to be able to manage the curriculum. Yeah. So we don't have cutoffs in terms of scores and grades, but we do need to be very sure that you're going to be able to manage this curriculum. And I guess from my own experience, both as a medical student myself, but then also, teaching in medical schools for the whole time I've been doing this, it's hard. Like medical school just is hard. It just is. Almost everybody shows up at medical school and goes, whoa, okay, it's a lot. My students who've been studying for their first exam that's happening right now, I've been like chatting with them as I pass by them in the school this week. And they're all going to the library again and again and again.
Yeah, they're appropriately kind of freaked out.
Yeah. And so and the thing is, like, I also want to know, like, to tell people medical schools are not making it hard to be mean. It's because, like, it's a lot of new information. in my opinion, as somebody who practices medicine, you have to know it.
It's a big responsibility. It's an enormous responsibility. Yeah. All that knowledge you have to be responsible for.
Right. Exactly.
I completely agree with you. That's one thing that I think we need to see. We can't look into a crystal ball and say this person's going to be successful, but we have to do our best. And I agree with you. We get that from an academic track record of what it looks like, and try to predict if we think they're going to be a viable student in our curricula.
Right. So for example, it's interesting, like I was reviewing applications yesterday, and I'll do more today,
Me too.
I think yesterday I said, there was somebody that I designated for interview whose undergraduate GPA was like a 3.15 or something, but he graduated in 2015. And since then he's done a post-bac program and another master's degree. And in both of those, his GPA in those programs was something north of 3.8. And he'd done really well on the MCAT. So I was like, well, I don't care what he was doing in 2014. That was years ago. You know what I mean? He's a different person now. So that's why we don't do that. But when I say like we're looking for a track record, I need to be quite convinced of like, okay, you're going to be able to manage this. So that's the most that I would, when people ask if those factors are the most important, like what factor is the most important, I would say we have to be convinced of that, or else it's a no-go. So no amount of passion and excellent work in other fields is going to convince me that you can manage the curriculum if the academic work doesn't convince me you can manage the curriculum. Excellent point. You can do all the research and helping people in Central America and all those things, but that's great. It's a wonderful, impact you're making, but really I agree that we have to have that reassurance that academically you're going to be okay. Right. So that's one thing. And then for us, when we look at all the other stuff, we really are looking at people that are going to kind of feel at home here and that are going to kind of, just sort of like how I felt when I took my job here, that I showed up and was like, oh, excellent. Turns out these people think just the way I think. That's kind of what we are. Well, okay. Think the way I think. That sounds like very restrictive. That's not what I don't mean. Please don't interpret that broadly. I'm not talking about politics here. I'm talking about people who are also invested in our mission of serving an underserved and diverse population. People who also want to approach their work with an academic bent and an inclination to contribute to the general knowledge by doing research. People who are really caring of others and have demonstrated in that lots of ways. So that's what we're looking for. And, the ways to demonstrate that, I think, are too numerous to count. So that is why we don't have like, oh, you have to do a minimum number of hours of such a place, because people would just like find ways to get
I got my 40 hours. So I check that off.
But that's not really the question we're answering. The question we're answering is like, do we think you're the kind of, does it seem like you are going to come here and be all excited about what we're doing and ready to jump right in and help? And so there are so many different ways to demonstrate that. Some of them are, okay, you went to UC Berkeley and you volunteered at the Suitcase Clinic, and then you became like the leader of the Suitcase Clinic, and then you did some innovation while you were there. And then also you decided, wow, this was really cool, and I'm pretty interested in social determinants of health. And so then you decided to go get an MPH or take some classes in public health, or maybe add a minor in public health. And then you did your senior thesis project on something related. And then, so all things sort of line up to make us thinking, we get it. All right, you are our kind of person. Yep. That's one way. But then another way is the person who comes to medicine from a totally different route. My family were immigrants to this country. I grew up in a community where most of the adults didn't speak English. I did a whole heck of a lot of translating for people. I saw many friends and family members not get adequate care. And I think that a gift that I have is being able to understand the science and communicate with my community. And so that's why I'm going to medical school.
So what you're describing here is holistic review. And that is a topic that I get a fair amount of emails about, saying all these people that you interview say they do holistic review and everybody does it differently. What does it really mean? And so I think people that are listening just heard Dr. Goodell describe how you what that means. Is that accurate?
Mm-hmm. Yes, I think that is what the originators of the term intended. But I agree with people that everybody says that they do holistic review, and people mean different things by that. So some people, for example, they're all different ways, and I don't know that one is any better than the other, but that's the way we do it. The other ways to do it are some people, I know some schools, for example, who do set a floor. Okay, we've decided that this is the minimum academic standards for entry. And once you meet that floor, you're getting an interview, and then we cross out those numbers. We don't let anybody else see them. And after that, we just decide based on the other things in your application. That's another way to do holistic review. So there are lots of different ways to do it, but that's the way we do it, is by trying to figure out, understand who you are and what you bring to the table. And I just in case it's not abundantly clear, context is an enormous factor. So for all of you who are out there worrying that you weren't able to get this opportunity or that opportunity, please know that we understand that, right? It is it is a million times. Like if either one of my kids wanted to do hospital volunteering, like they could, because I work here. And like I could just call up the volunteer office, who owes me a couple of favors anyway, and hey, can my kids come? And they'd be like, oh yeah, sure, Dr. Goodell. Like that's easy, right? Not everybody has that, and we get it. Like please know that we get it, and that's true for. I have yet to determine a metric for medical school entrance that is not influenced by privilege. I can't think of. They're all influenced by privilege. So we're trying to do the best we can to mitigate that. I think the best way is to try and understand people's context. So to those of you listening, please tell us your context. Another thing that we do at BU is that we send every single person a secondary. It's because our secondary application asks about context. It gives you opportunities to tell us more about who you are and what your background is, how different things have impacted you. And so the reason we do that is because we don't want to do any interpretation without really understanding where you're from. And that goes for COVID as well.
I was just going to say, speaking of impact, and I listeners, that they've been listening, they've heard me bring this up multiple times, but I just think they need to hear and keep hearing that. How are you going to evaluate all the things that have been disrupted and canceled for pre-medical students that are applying to you this year? What is your approach to it? What's your admissions committee or screening committee kind of been charged with in assessing that this year?
So we just know that the applications don't look the same as they did in previous years. I think in previous years, I probably would have sort of scoffed at virtual shadowing. And now what I think is this student was doing the best they could. That was the opportunity they had. They did it, So I think, I guess just know that we know that all the applications look different and you're swimming in the same pool as everybody else, right?
It wasn't just like Massachusetts or just the students in Maine are impacted. It was everybody. Everybody's stuff was shut down. So, and the core, so I talked about the core academic question being like, are you going to be able to manage the curriculum? And then I talked about how the people that stand out to us are the people that are really very clear mission fits for us. But in terms of like what else it takes and what the other, so when we're looking at the rest of the application, there are questions that we're trying to answer that are sort of the minimum standard questions. And so those are, it's not how many hours did you do of this or that. It is, does this person have enough clinical experience to know what they're getting into? And so that can come in about 1 million different ways. Like there was another application that I read yesterday where the person had, I don't know, maybe done a tiny bit of shadowing or something. I don't really remember, not much. But on the other hand, had themselves had a significant illness and then had cared for their grandparents at the end of life, which, and so that's actually, and like lots of interactions with the medical system that they wrote about. So this was like, all right, this person knows what they're getting into. So that's one of the questions. We just want to make sure that you know what it's all about. And as crazy as it sounds, people who are listening to this podcast are probably not in this group, but we do get applications from people who I think are like, what the heck? I think I'll just apply to med school. And like they're really smart, so they get kind of far in the process. And, so we want to make sure you know what you're getting into. The other big question that we're looking for is, have you demonstrated evidence that you are inclined to serve people, to help people? And while like
2020, such a kind of easy way to do that was like, oh, I'll volunteer in the hospital and then I'll get clinical experience. Plus I'll also show that I'm helping people, 2 birds, 1 stone. So fine. But this past year I was amazed and like really thought it was beautiful. The ways that our applicants found to take care of other people that were not as part of a program, not anything from a pre-health advisor. This includes, a woman who got sent home from college, was at home on Cape Cod, didn't kind of know what to do with herself, really wanted to do something to help out in the pandemic. And so she started reaching out to neighbors. There were a lot of elderly people, and she started reaching out and saying, hey, do you want me to go do your errands for you? I can just do that.
Yeah. Yeah.
Many people who supervised online school, either for younger siblings or neighbors, people in their neighborhood. Many people who might have done some sort of I'm going to establish this science mentoring and tutoring program in this one particular neighborhood. Well, instead, they reached out to their old elementary school principal and said,
how can I help?
Be helpful.
Yeah.
So these things I don't know, they make me tear up. I just think that's the kind of person. So it doesn't have to be, we're just looking to see that you cared and you were trying to do the best you could.
Yep. Thank you for that. Cause I just, as I said, I like to have people reiterate it and hear it again and again to know, because there's always this very high level of anxiety for students that initiate this process, which we talked about before we hit record for something else. But it just to continue to hear that we get it. And we're trying to put us all into context with your story and what you've had to go through in the last year. So we get it that the applications are not going to look like they have for the past several decades, the same kind of things that we've been used to seeing. One other thing I wanted to ask you about, before I ask you about your research and with some of that research you did with MCAT, Casper, you're acquiring Casper this year. And I asked you, I said, can I ask you about that? And you said, oh, I'd love to. So how are you using the Casper score? Which is, for those that don't know, it's like a situational judgment test kind of online assessment, if you will.
Right. So the reason that what I liked about Casper when I learned about it is that it seemed like a way to try to get a handle on some personal characteristics or skills that are essential for physicians that are otherwise very difficult to assess in the context of an application. And these are things like empathy, judgment, your inclination to teamwork, communication skills. And I don't mean to, there are other things that we can look for. We can look at your activities and see if they demonstrate empathy. But frankly, people write about things in the best, most positive way on their application, which is the right thing to do. But it's hard to tell sometimes if that was really coming from your heart or if you were just
incredibly well-groomed essays that have been, people have gone over them and other people have helped you write them.
So and even the experience descriptions and stuff. So we look for stuff like that. And then, okay, you can look at the letters of recommendation to see if sometimes the letters talk about these key things and sometimes they don't. And it kind of depends on the letter writer. Right. And honestly, a lot of the time that's not the applicant's fault.
Oh, no. Yeah.
And and not to mention also that nearly everybody can find someone to write a nice letter for them or to, 3 people or whatever. So I think those are qualities that are really difficult to assess, but I don't know any doctors that don't think that they're a critical part of the job. So I was mentioning medicine is hard. Part of it is that it's very academically challenging, but in addition to being way smarter than average, you also need to be a way better communicator than average. And also, more empathetic and compassionate, although I don't know how. Maybe the average person is really empathetic and compassionate. So maybe that's okay. I don't know. I don't have a good scale for that one, but I think you have to be able to do all these things. So Casper kind of promised a way to assess that. And I thought, all right, that seems pretty good. The Casper people have really excellent research to back up their product, which is one of the things that won us over. But the way, and so I thought that seemed promising. The way we are using it, and by the way, this is also how I've heard my colleagues that are using Casper or a similar test. This is how I've also heard them using it. We do not use it as a weed in or weed out tool. It is one of a number of factors that we consider when we are reviewing the applications. And we actually keep it as part of the application all the way through. This is not, in my opinion, this test is too new and lacks sufficient evidence for us to make it too big of a factor, if that makes sense. It's more that we incorporate it with other things. So if somebody looks great, but they've got a really low Casper score, I'm like, well, I don't know what to make of that. It's too new for me to say, ooh. On the other hand, if somebody's writing is a little awkward and their interview doesn't go that well, their letters are tepid and they have a low Casper score, then we're like, I don't think so.
Maybe it correlates a little bit with something that you saw.
Even if they did amazing research and have terrific, academic metrics, then we might be like, not sure this physician thing is going to be the right thing. You know what I mean? So that's kind of how we use it. And conversely, we've also had a couple of people who were just, maybe they, I think Casper might actually sort of maybe overcome a little bit of initial anxiety or shyness, if you will. So there are always people who worry about interviews because they're nervous about the interview. So if people are nervous interviewers who are quiet when they're nervous, and then they've got a bunch of letters who say like, oh, this is like a quiet, diligent student, did all their works, seemed to do fine, but then they have a super high Casper score. Then I think like, okay, it's not that they're not engaged. Right. There's no problem with their judgment. They're simply introverts. Right. Yeah. Fine. Like them too.
We need introverts in our classes. We can't have classes full of bombastic, extroverted people. So we need a whole mix of different types of personalities. Oh, that's cool. The other thing I want to ask you about is not only are you doing admissions work every day, but you're also doing some research in it. And when I was looking at your biography, you did some recent work in analyzing the middle third of MCAT scores. And what did you find from that? Just like in a kind of a snapshot.
Yeah. So basically what we found is that, we looked at, and this is, I should say, I'm part of the MCAT Validity Committee. This is a committee that is convened by the AAMC. That is the people that own and produce the MCAT. So I just want to make that potential conflict of interest clear. But they don't pay me, but anyway, we looked at the MCAT score and we essentially broke the MCAT score range into thirds. And then we looked at, okay, how many people, first of all, are accepted to medical school that have scores in the bottom third compared to the middle third compared to the top third. And then we looked at, and how do those people perform? And what we found is that the people who are accepted to medical school with scores in the middle third of the MCAT scale, so this is something between it changes a little bit year to year, but like a 497 to a 504 or something like that. I don't remember the top number very well, but anyways.
Sorry, MCAT, but it's the craziest grading scale. Yeah,
it is. It's totally hard to remember. And I don't remember like what the 70th percentile is.
It changes every year, but like the top score is 528 and the lowest score you get is 474 or something. Anyway.
Yeah, I just thought the top is 532. But anyway, you see the problem. Yeah. Anyway, so we looked at the students that go to medical school that have scores in the middle of the vast majority of them progress through the curriculum, graduate in 4 or 5 years. The vast majority of them progress through the curriculum on time. They start third year on time. The vast majority of them pass step 1 on the first try. So those are, and then so that's the important thing to know about the middle score. And the other thing, when we also looked at the middle third of the scale, what we found is that those students are dramatically more diverse than the students with scores in the top third. And we looked at a number of different diversity factors. We looked at socioeconomic status. We looked at race and ethnicity. We looked at being a first-generation college student, living in a rural area. There were 6 factors that we looked at. And students in that middle group were much more likely to have one of those factors, and they were much, much more likely to have 2 of those factors compared to the students in the top with scores in the top third. So our message to people out there in the world is, hey, remember how we've all been when they surveyed medical school deans, and 99% of the executive deans of medical schools said, yes, we want to make our classes more diverse. So our answer to that is like, okay, so you can calm down about the MCAT scores a little bit and accept more people with scores in the middle third. You don't need to worry like, oh gosh, are they going to do okay? The answer is like, yeah, the vast majority of them. And when I say vast, I mean, like, it depends on the specific number, but I want to say that it's something like 88% of that whole group.
Pretty high, very high. Yeah. Oh, very interesting.
For people out there wondering, although almost everybody that goes to medical school graduates from medical school, the idea, like, there are hiccups along the way. And I think people, so it's not.
That's a question we get a lot, is like, how many people drop out? Like, gosh, we kind of joke internally here. It's like, it's really hard to get in, but it's also really hard to get out. There's multiple safety nets that come under students. So if hiccups come along the way, it's not just like, whoop, okay, you're gone. We want to keep you in. Okay, let's just to kind of wind things down. I want to talk about your interview day briefly, and then we have applications staring at us. What's your plan this year for your interview day process? Online, hybrid, in person? What's that going to look like?
So we are keeping our interviews online this year. We freed ourselves from the structure of an interview day. And that was because I don't like being on Zoom for many hours in a row.
Most people don't.
And it doesn't matter to me. Like, I don't have to be on Zoom for many hours in a row, but I was thinking about myself as an applicant, and I just didn't want to do that. So we have 3 things that applicants have to do. They have to do an overview session with me where I talk about the school. They have to do a session with students that's student run, where again, they're talking about the school, but it's the chance to sort of meet our people and find out like, okay, who are these people? Do I like them? And then they do their interview. So there are 3 components, and those can be scheduled all on the same day or in the same half day. But also they could be done. They don't need to be done on the same day. And so we really just tried to make that as flexible as possible. We do ask that people do the overview with me before their interview. It's actually really to their benefit. If they don't, then they go to their interview, and the interviewer, we had a couple times this year where interviewers wrote in their reports, I don't think this person's that interested in the school. They didn't seem to know that much about us. And I was like, that's because they didn't go to my thing.
Yeah. Yep. So good tip.
Like where I tell you all the points.
There's your tip.
So there's your tip. And we tell people to do it before, but not everybody listens. But, also as a medical student, like, you should follow directions.
It's important. Details really count. Details count. Yeah.
So those are the 3 components. You can do them all on the same day or not. And then what we are going to do is, starting in the winter time, we're planning, barring unforeseen circumstances, never say never, but currently the plan is, starting in January, we will have a series of optional in-person visit days for accepted students. That's because we really do want to give people the chance to come and kind of see what we're all about. And I think this is a big decision, but on the other hand, it was pretty clear to us after last year that we could do a perfectly reasonable job of the evaluative part of the interview. Like, it was fine, even though I would rather talk to people in the same room.
I know. I'm with you.
It was fine. So it was just like, it just doesn't seem quite right to ask people to shell out all that money and travel. And like we've got our applicant pool is national, so people have to get on a plane and, take it off work or school. So we are the in-person days will be only for accepted students, first of all, and they'll also be optional. But we'll have that option for people that are
want to come and see. Have you gone down the road yet of looking into the future that this might be the way you keep doing it, or just kind of year to year, like, we'll see how this year goes and then reevaluate? Or, because I know some schools are like, you know what, this is it. This is what we're going to do. We're going to keep doing it online because of the equity issues that were exposed last year. And like you mentioned, the financial issues that strains it puts on applicants.
Exactly. So I think that we are more likely than not to keep doing it this way, with online interviews, but an option for people that want it. And it really is because of equity. and fairness. It just doesn't seem fair to put more of a burden on people, especially like if you haven't even gotten in yet. And the idea of having it optional, I really worry that that's kind of like, that's going to be really unfair, because then people are going to be compelled to come. And I don't know. The other thing is, freeing ourselves up from the structure of an interview day also made it much easier for our interviewers. So we had quite a fixed schedule. Like, you have to do interviews Monday, Wednesday, or Friday at 8 a.m. or 9 a.m., which was like nice and easy for my office. But on the other hand, it was terrible for interviewers. Yeah. And so it's easier to get interviewers because they can do it. Whatever time they have free during the work week. I agree.
We saw the same thing. We were able to retain more of our clinical interviewers a longer period of time over the course of the interview season, because you'd see them pop into their office while they're seeing patients that day, but they could pop in for 45 minutes, interview a candidate, and then walk right out and get back to patient care.
Right. Yeah. It also made it possible for us we can have Kaiser people.
Oh, right.
That are on the admissions committee now, because it doesn't matter if they're in California or Boston. Oh. So they, which is really
that's
good.
Great. Really quickly about your interview day, they get one interview or two?
They get one interview, one faculty interview. Does
the faculty interview have access to everything in the application, or are they blinded to anything?
The faculty interviewers are our most important evaluators of the application. So we have whoever does the initial review. There's a group of 15 of us that do those. They kind of decide who gets an interview, and there's a standardized process for that. And then the interviewers really read just every word of that whole application, and they evaluate the application. We use this online evaluation system, and the interview is part of their evaluation of the application. And so then they fill out this online, it's like they write a report basically, and then that just gets added right to the application file. And so then at the very end, not the very end, but there are selection meetings. We have one selection meeting in November and one in February. And the whole admissions committee, again, it's the same people. It's all the interviewers are on the committee. Okay. They come together, they break up into groups of 4 or 5. Each group of 4 or 5 gets a virtual stack of applications, and they go through, they discuss each one and make a recommendation about what to do. And so they are discussing the interviewer's report, but they also have all the stuff. Yeah. And sometimes they agree with what the interviewer says, and sometimes not. Oh, wow.
So your admissions process, or the notifications are not rolling. Do you do them at 2 touch points or all at the end?
Yeah, we do them at 2 touch points. And really, it's interesting. There is no difference between that first group and the second group. It's not a prioritization or anything. We just can't. We interview 1,000 people. It's a lot of people. A lot. So we just can't do it all in one day.
Yeah.
And so we do half and then the second half.
So for people to hear that, if you're in group 2, it's not, you're not, it doesn't matter. Yeah. It doesn't matter. Yeah. You're hearing it here from the dean saying that. So, okay.
Yeah. And it might have to do with when you submitted your application. So if you don't submit your application until September, then you're probably going to be in the second group. But whatever, there are a bunch of people that end up there that submitted in July, and it's not anything bad. It means because this person said they were going to do the review, and then they went out on maternity leave. And so then we had to disperse it and we gave it to somebody else, or, this person wanted me to look at it, or whatever. Yeah.
So don't overanalyze it. It. Hey, after then, so if I'm an applicant and I find out the news that I didn't get in, I wasn't accepted in that from the selection committee, but I've been placed on your wait list or alternate list. Do you want to hear from me, or do you have enough information and just don't call us, we'll call you?
That's a great question. It's perfectly fine for me to hear from people. Anything that you send us, we just upload and attach to your application. And then really when we look at it is the next time we look at your application. I think the later in the process we are, the more important it is.
Agreed.
So, if you have an interview and then you send me a note saying, oh my gosh, Dr. Goodell, this was my favorite thing I've done so far, and I love your school, and it's October, I'm going to be like, whatever. You didn't even go to Case Western yet. So I treat that like a thank you note. It's polite, but doesn't really mean that. But on the other hand, if we are in April or May, and we are at this time, and you're on our wait list, and you're like, okay, I have a plan A for medical school, but you guys are my favorite.
You're my people.
And if you let me in, I'm coming. Then like, that's actually quite meaningful because we want people who want to be here. So I think later on it makes more of a difference.
Be strategic about it. Be strategic.
Yeah. And just, you don't have to do things. I know it seems like we put these hoops out there for people to jump through just to make life difficult, but like, this is not one of them.
We have others.
Yeah.
Oh, that's great. Is there anything that we didn't, we covered a lot of different topics and this has been a thrill for me. You're a great person I can tell you love this. And you love what you do, both as a physician and as a dean of admissions, and as a mom, and as as a preceptor, a mentor. Do we leave anything out? Did I not ask you a question you wanted to talk about, or you were expecting?
I don't think so.
Yeah.
I don't think so. I can't think of any of the highlights that you left out. I always ask people when we used to have people come in groups, and I'll do this now, and people come back again for visits, or I do this when I talk to people online too. I always ask people if they have any questions about the seedy underbelly of admissions. People are like, give us the lowdown. Like, what do you, and every now and then an applicant will be like, do you guys really read the letters?
Yeah.
So I love questions like that. To me, that's the only thing that's missing. But your audience doesn't get to ask questions.
We do. Podcast. Now, do you guys wear black robes for your selection meetings and have candles and stuff in the room like we do?
There's chanting. Yes. Actually, have you seen Animal House? Yes. No, I'm just kidding.
Oh my gosh. Oh, that's. We get a little irreverent, but we do take it very seriously. But
ours are very serious. I try to apply the selection. The admissions committee members. We give them food, we give them coffee, and try and keep them in good moods while they're doing their work.
Yep. Snacks are important. Food is important. Well, Dr. Goodell, this has been fun. This has been such a treat, and I'm so grateful for spending as much time as you have with me today. And I'm sure people that are listening are going to get a real kick out of this too. So thanks for doing this.
Oh, well, it was my pleasure.
Yeah. Well, I can't wait to meet in person too at our next AAMC meeting or something. I have a lot of people I have to meet and thank in person. So I'm going to take my list of people I got to track down, and you'll be on that list. So thanks a lot.
Yeah, you should have a reception.
That's a good idea, like an alumni.
You should have a little reception at AAMC. You should invite me. I'm really fun.
Well, you sound like a really fun person, and one of the reasons why I started this was we were sitting in a lobby. It was at the PDC in Orlando a few years ago. There's all these admissions people in this huge hotel lobby, and all we're doing is talking about admission stuff. And I thought, if you were a pre-med kid walking through this lobby, it would be you'd just try to sit down and listen to everything people were talking about, because it was all talking about SHOP. And I thought, how can we bring them into those conversations? And that was one of the places that brought me to doing this. So, and also to bring a voice and some personality to schools. So you have definitely checked off those boxes in a very meaningful and cool way. So thanks so much.
Well, thank you for having me. It's been really fun to talk to you, and I hope this is helpful to the people listening.
You bet it is. All right. I'll see you around. Thanks.
All right. Take care.